right, so then again, welcome to the North Dakota and South Dakota Provider Networking session. And again, this is your session to talk about anything related to COVID or just even state issues. Literally, this is just your call. We do have several folks on the line, and traditionally we'd like to have everybody introduce yourselves, but the issue with that, it does take a long time. So I think I'm just going to highlight a few folks that you will make sure you want to know. And that would be your North Dakota and South Dakota board members. So if I can have both, thank you, Brenda. If I could have Kevin, if you could introduce yourself to everybody. I'm sure everybody already knows you. But if you can introduce yourself and say what company you're from and what you hope to accomplish out of this session.
Thank you, Rose. Well, I'm Kevin Holzer. I've been with Great Plains Rehab Services in Bismarck, North Dakota. As the Assistant Director, I've been here for about 21 years working in this capacity. I guess Brenda and myself from your home in Grand Forks are here as your representatives for North Dakota to continue to work with you with your questions. We have some great contacts with Medicaid, some Blue Cross, and being we're in the business for as long as we have some pretty good contacts, and we'll continue to try to make things better for everybody and kind of be your spokespersons whenever possible.
Awesome. Thank you so much, Kevin. And then Kevin mentioned Brenda. Brenda, are you able to speak and introduce yourself as well?
I am. Hello, everybody. My name is Brenda Schultz, and I work for Your Home Medical Essentials up in Grand Forks. And I've been with the business or the health system for close to 30 years. So we do have a lot of contacts, like Kevin said. Kevin and I work a lot on a lot of different things. Be very happy to help anybody with any kind of contacts or information that we have. I can about imagine everybody's been in the same boat and struggling through a lot of what I would say oxygen setups, things like that. I do have a little bit of info if anybody's interested on covered people that don't have any insurance and how to get reimbursed for them. So if anybody's interested in that, I can help share that information. So welcome on the Zoom meeting.
Awesome, Brendan. We'll definitely be wanting to hear from you. Do we have Cindy Coy on the line? There's a couple of phone numbers. Cindy, are you? Not yet. Okay, Cindy Coy is right now your South Dakota Board of Directors. She's a state chairperson. And Cindy is a Lone Star. We did have a vacancy in South Dakota. So if there is any members in South Dakota that would be interested in helping Cindy out and representing South Dakota as a board member, let Cindy or myself know. Cindy is from the Avera system, and I would expect she'll probably be jumping on pretty much hopefully soon because she was available. And so again, there's a couple other folks here. Nancy Frousley, she's one of our folks that is a chair of our rehab committee and also our retail committee. So she's been very engaged and active. Nancy, you want to introduce yourself?
Hi, sorry, I had to unmute myself. My name is Nancy Frousley. I actually work for a company called New Motion. I started with them just 2 months ago, but prior to that, I worked for the Sanford Health System for nearly 24 years. So I have a lot of background in not only the rehab aspect of things, but also, like Rose said, the retail side of things and just, all the aspects of a full service DME. So happy to be here.
Thank you, Nancy. And the reason I wanted to highlight Nancy as well, this type of meeting was kind of born out of our retail committee. Last month we had the retail committee was like, I'd really like to get all providers together, retail providers together. With the spike, I'm really struggling. Do I do curbside again, you know, shut my store. I mean, all these things that were happening. And so they actually were the ones that requested to do a provider roundtable discussion and ask each other questions on how they were handling certain things. And that was again last month, and it went so very well. I didn't hardly do any talking. They did all the talking. But from that, there was just some great discussion back and forth, and it was more than just retail. And so out of that idea, we presented the opportunity to the board members, to Kevin and Brenda and Cindy, and everybody was all over it, to do it by state. And so that's how we got to this point. So anybody else want to share anything, or otherwise we'll just dive right into open networking. Okay, no Cindy yet. All right. Okay, so with that, I'm going to turn it over. Brenda, since you started that idea about the non-covereds, because that's starting to come up quite a bit, of what in our other state networking sessions, I've been hearing a lot about that. So do you want to kind of open the meeting up about non-covered?
Absolutely, absolutely. So there is a program out there. It's called HRSA, and it is a program that will pay providers, and it does include DME providers, for any patient that is uninsured and has a COVID diagnosis. And so what I would encourage you to do, you do need to sign up for it. It does need to go through you can bill it right through your billing program if you have the right clearinghouse. It does give very good instructions on the website. If you just Google HRSA COVID-19, it'll come up with a really nice website on there, and it's step-by-step instructions. And so I would encourage you to utilize it if you have patients that just don't have insurance. Now, I don't believe it will cover for patients that have a co-insurance, but most insurances are waiving that at this point anyway. But keep in mind that the patient does have to have the COVID-19 diagnosis, which is U07.1, I believe. So just a little tidbit of information and to help out with some expenses, because obviously if you're a self-pay patient and you have COVID, it's going to be a struggle to get to pay that. So any questions on that? You're muted, Rose.
I know, I was typing. I can't be quick enough. Have you billed anybody to that program yet?
I'm just submitting this week.
Oh, cool.
So I've just been working on it all week, and I've got it all ready to go. So they say it pays in a couple weeks, so we'll see.
Cool, because the other discussions that have come up, I don't think anybody had billed yet. So keep us posted, because it's really good info.
Yeah, and I know that our health system does quite a bit of it. But I was glad to see that DME was included. So.
Cool. Anybody else have experience with that?
Brenda, I assume that's a federally funded program?
Yes, it is. It is it's through CMS, I believe it is. So it's federal program, and there's a number to call on there if you have any questions. It's very easy to maneuver through, so don't be scared of it.
Rose, can you hear me?
Yes.
Okay. Cindy will be on shortly. She's on another call. We do bill the uninsured program or the HRSA program, but Cindy can attest to whether we've actually done the billing yet or not, but we do participate in that.
Awesome. All right, anybody else? All right, hearing none. One of the other big discussions I think I'm hearing from folks, because we had asked for questions to be submitted ahead of time, and most of the questions we've gotten surrounds about, are you having problems getting PPE and respiratory equipment? So I'm going to throw that one out there for back and forth discussion then.
Well, speaking for Great Plains, as far as PPE goes, you know, we work with Dakota Drug quite a bit as far as one of our primary vendors, along with Cardinal Health. And as far as getting all of any PPE that I want, it has been quite good. We get gloves from Medline. If you didn't purchase from them before, you're not going to get any gloves, but they still stay with your allocations if you did establish an allocation before the COVID time. So that is, it's nice that we have that. We also have for North Dakota. I have used the North Dakota Department of Health has a catch, if you will, of supplies. And when the epidemic started, a lot of these vendors didn't have the product, and I was able to utilize the North Dakota Department of Health's storage, and they were fantastic to work with as far as being able to get PPE.
This is Pat. We've also been able to get a lot of allocated supplies from McKesson for PPE.
I've been hearing a lot. There's been challenges with people that you get your allotment, but it's not even keeping up to what the volume has been with their existing patients. Have any of you had to like not take any new glove customers, or how are you handling that?
Well, I'll speak on that one as well. As far as gloves go, we haven't sold gloves since the epidemic started, honestly. We had to keep our glove supply just as far as what we're consuming. So unfortunately, not being able to sell any gloves. We do give out masks and such, but as far as gloves, that's not something we can do. I know in the earlier question you had too, as far as some of the backorder situations or trouble, particularly with oxygen, we do use Respironics concentrators, and they are in a backorder situation till the end of December. We luckily, you know, at least have a couple stores, so we're able to work with our Dickinson operation as well, as far as utilizing oxygen and such, having those supplies between the two locations. But it's we're on the list as far as things on order. We're keeping things on order, even if they say it's on back order, so that we can be first up when supplies do come out. But at this point in time, between CPAP masks, headgear, and concentrators, we are having some difficulty with back order situations.
Anybody
Hi.
else? Oh, hey,
Hi,
Cindy.
Rose. I just wanted to let you know that I joined. I'm sorry for being late.
No problem, understandable. Cindy, if you want to quick introduce yourself as the MAMES state chairperson for South Dakota and on our board.
Sure. My name is Cindy Coy, and I am with Avera Home Medical Equipment. I am located in Sioux Falls, South Dakota. And as Rose said, I am the state chairperson for the state of South Dakota. Also a board member for MAMES, and on the education and regulatory committee.
Yes, we appreciate Cindy very much. Adds a lot of value. How about so on your backlog or back order of concentrators and things like that, are any of you like networking with other systems, like, you know, what we've been hearing in other states? Providers are worried about ordering all these concentrators or hospital beds, and then once COVID is over, you know, you're going to have this warehouse full of equipment, you know, so they're worried about what they're trying to do. So a couple of folks have indicated, you know what, we've really kind of established a network of, you know, some of our peers, and You know, one area may be doing okay in relation to infections, and so they do report that they're working with some of the other providers, just kind of, you know, borrowing things out, if you will, or you know, buying them cheaply, whatever. Are any of you folks finding any of that success? All right. Hearing none.
Nancy, you were on mute if you were talking.
Well, I wasn't, yeah, I was talking to someone was talking to me, but,
Oh,
but
sorry.
I do have no, you're fine. I do have a question though. I'm just curious, I was on another call a few weeks back where this company took a really deep dive into what it was costing them to provide their employees with PPE, to provide their customers that came in with PPE. And it was going to cost them like an extra $98,000 a year in just PPE expense. And so what they did is they actually raised prices on some of their self-pay stuff just to kind of offset that. And I was just curious if any other providers have done a deep dive as to what your PPE expense is going to be this year and even into 2021, and if you've done anything to kind of offset that extra expense.
I'm not 100% sure with this, so Mary Claire, if I'm wrong, please correct me. But I think for us, we took part of the Cures Act money that we got and put it towards that. So if you all remember, if you applied for that money and got it, it actually needs to be used for something related to the pandemic. And so we kind of looked at that as part of what we would, you know, kind of put towards the money that we had gotten from the government. So that's kind of how we're handling it. I don't know about it. I don't know if anybody else had the same thing. I'm not sure.
That was a great idea. Unfortunately, this is Kevin, but we didn't. We just tried to make sure that our budget looks a little bit better than what we want it to. Unfortunately, it's a big expense, Nancy. You're right, and we really haven't. Obviously, it wasn't in the budget, so it's.
What'd you make?
Pardon me. I thought somebody else was piping in. So we're just going to try to weather the storm, I guess.
Yeah, I was actually pretty surprised. I don't have my notes from that call that I was on, but the gentleman that did the deep dive, I mean, he had it down to how much it costs per transaction based on how many transactions they did the prior year. And it was like 40 some cents. And I mean, he had it so broken down into how much this was costing him. It was really kind of stunning, you know, because I think we need to get PPE for our employees. So we just get it. And it's just, you know, kind of the cost of doing business. But, you know, boy, when I was looking at what he had laid out for the true costs of what it was costing him to keep his employees safe and then to keep any customers that were coming into his store safe, it was really stunning. And he only has two locations with, I think, 8 total employees or 10 total employees. It's a smaller operation. So it was just really stunning to see it, you know, really down into the weeds for costs.
Especially with the gloves. Gloves, it sounds like when you guys get your allotment, the price just keeps going up pretty much every time you receive a shipment. Are you guys experiencing that too?
Yeah, we're paying 3 times as much for gloves as we used to now per box.
Do your Medicaids pay for the gloves?
Do we sell to Medicaid? Is that what you said, Rose?
Yeah, I mean, do they pay for gloves if you sell to a Medicaid patient?
We don't sell any gloves to the Medicaid side.
we've been hearing in some of our states, I think like North Dakota, they will pay Medicaid if there is a Medicaid client that needs medically necessary gloves for any type of condition, they will reimburse, you know, they will pay on those claims. So there's quite a few folks that do have Medicaid patients that use gloves that they get reimbursed for, which the, you know, reimbursement used to be okay. Well, now they're underwater in every transaction, and you know, with a Medicaid client, you can't pick and choose. So many states are trying to work with Medicaid offices to try to see if there's any movement or wiggle room and how they reimburse gloves, at least through the PPE or through the PHE. And then Travis did share, if you guys, if you do see chat, he also indicates that Cardinal Health, Dakota Drug, and Sunset Healthcare has been a good source for PPE. All right, any further discussion about that issue or any type of equipment shortages? Good discussion, Nancy, because I have not heard of anybody that's gone through and done a deep dive on what the impact of having that is. I have heard about what Cindy said, the CARES, they're reporting their PPE, you know, as part of the CARES reimbursement, and we'll continue to do that. All right, the other big topic that keeps popping up, and I think Brenda, you folks brought this up, and we're still waiting to hear back from CMS on it. As you all know, the Medicare rules, when they changed early on, when they had the waivers out there, that you would not have to get a delivery slip signed if it was a COVID patient. And one of the things that I think most people miss from the get-go, based on everything I'm hearing, a lot of providers have their assignment of benefits on that delivery slip. So you always were covered. You'd have your delivery slip signed, the assignment of benefits was on that form, and you're covered. Well, what didn't happen is CMS did not waive the requirement on the assignment of benefits. You still have to have a signature, and almost every single supplier, provider member I've talked to, they're handling it now, but they didn't initially. And so obviously everybody's worried about the whole side of the audits and what happens if they're looking for AOBs. You know, when this all first started and the confusion was rampant. So I would love to have you guys talk about what you guys are doing to get your assignment of benefits. There's been some creative stuff being discussed.
So this is Brenda, and I like Rose said, when they first started out waiving that signature, it was never identified that your authorization needed to be signed so that we can legally send to their insurances. And when I heard that on a seminar or a webinar, probably midsummer, I think everybody on that webinar was shocked and very taken aback by that. And I've been on other ones with Cindy White, and they really don't want to give you an answer. They say they're checking into it, but as for now, you do need to get that signature. I talked to our registration within the health system and asked how they are doing it, because they don't always get signatures either, and they're doing it verbally and writing verbal on the paper. Whether that's right or not, or will be passable in an audit, I don't know. I don't know if others are getting audits. We're getting a number of audits right now, and one audit was asking for a delivery ticket, and it had no signature due to COVID, and they're still asking for a delivery ticket. So it kind of concerns me a little bit how strict they're going to be on this COVID signature. So I'd like to hear what other people are doing for their, if they're using their delivery ticket for assignment of benefits, how they're getting that signature.
Well, Brenda, what we're doing at Great Plains is we do use the COVID signature if we're having to supply to those individuals that are COVID positive, that don't want to come into our, that we're doing a curbside delivery on, or potentially even from the hospital. So we do use, again, the COVID signature, but every one of those from the very get-go, from the very start, because I don't trust CMS Medicare very much. I think if we put too much trust in that, we're going to get blindsided, like some people are possibly getting blindsided today. But we always sent an AOB on any first-time purchase orders for those particular codes. And again, did it back in March and doing it today yet, just because we figured we're going to be audited someday. And I'm glad we stayed the track that we were on, because nothing's free with Medicare, I don't think, and they're not going to change too many of their rules and regulations for COVID or not.
I agree. I think the more cautious we are, the better we're going to be when these audits come up.
Brenda, what, may I ask, what audit? And you said, so you said you actually got an audit on they were looking for a signature?
They are, and we actually, I have a telephone conference with it, I think in the next week. I have a couple coming up and one of them's on that. And so I don't know, my hope is that they're going to waive this COVID, but we had sent it in and they're still asking for a proper delivery ticket. So I just fear a little bit of what's not right about it. And my hope is that we can talk through it when we have the telephone discussion. But like Kevin said, CMS is scary.
What's your data? Because I maybe I missed it. I know that they went back and did audits, but I didn't think they were supposed to do anything during any audits during the PHE. Am I?
They are now.
I'm on vacation then, I guess, because I did not know that.
This one was, I've gotten several that aren't, but this one happened to be during the COVID. I don't have the date in front of me. Yeah. So
We've gotten some rack audits, and oh, what else did we get? CERT maybe, but they were all from timeframes before the pandemic. So we haven't had any recent claims audited. Knock on wood.
Yeah, so it'll be interesting. I'll keep you guys updated what we find out on this one. Like I said, we've had many, actually from 17 and 18, they're hitting us hard, but this happened to be one during the pandemic.
So strange. Okay. Anybody else?
I'm just wondering, do you know what type of audit it was?
I don't have our building staff has the paperwork, because they don't have it in front of me.
Okay.
So I don't know for sure. So my hope is I find out more on the telephone conversation when we have the follow-up on it.
We just received 4 rack audits last week on TLSOs, and those are from 2018 actually. We haven't had a whole bunch of from Medicare racks and such, but this is kind of the larger one that we've had here in recent time.
And what was it on, Kevin?
It was on TLSO.
Okay.
And all 4 of those were TLSOs. I don't know, they're picking on us on that one, I guess.
But 8 catheters too, they're really picking on. We had a number of them.
Yeah, we've had a number of catheters and TLSOs as well.
Rose, had we talked yet about some of the bills and things in Washington that we possibly could reach out to our legislators about?
Nope.
Would you be okay if I
Sure
visited about that?
Mm-hmm.
So
currently
in the House, there is a bill, HR 8158. And what that is, it's to eliminate the outdated oxygen budget neutrality provision. So what they're asking is that that we get basically get an increase in what it's costing us to do business, or get an increase in payment to make up for what it's costing us to do business, especially for oxygen. I did reach out in South Dakota, I did reach out to Thune's office, Round's office, and Dusty Johnson's office. Have not gotten answers back from Dusty's office or Round's office, but I did get answer back from Danielle at Thune's office, and she kind of wanted to know what the score was on it, so that they kind of want to try to stay budget neutral, which I get as a taxpayer. I totally get that. But I answered her back and said, you know, we are working overtime. We've got people working overtime. We're having to buy equipment at a much larger price than what we normally would. And so our cost of taking care of these patients and keeping them out of the hospitals has gone up tremendously. And so basically just asked them to support that bill, make sure that they, when it comes up for vote, that they support that bill if it does get to the Senate. The other thing that I asked them about was extending the 2% sequestration relief. That is supposed to expire on December 31st of 2020. And we would like to see that extended. I don't know what the possibility of that is happening, but we would certainly like to see that that extended. So any thoughts on any of that, or has anyone else reached out to their legislative folks? I will take that as a no. So if you would, I could certainly send you the talking points, or maybe an example of one of the letters or emails that I sent, and you could do the same. Do you have a email group, Rose, that I could send it to, or just, okay. But yeah, if you guys could reach out sooner than later to your legislative folks, I think both of these would very much help some of the struggles that we have. I'm sure that you as well. I mean, we're having to put more and more folks on call and different things like that. We've got people working overtime, which I'm sure you do as well. So any relief that we can get would certainly help that. Any discussion?
Well, thank you, Cindy, for bringing that up. Definitely something that I'll do. Is I was just reading on the oxygen neutrality budget here just today. Be a good point to go ahead and reach out and make sure that they know that what our thoughts are. And you're right, it is costing us a whole bunch more on overtime, callback, lots of extra effort, as you indicated. We're seeing that here in North Dakota as well.
Yeah.
Thank you for bringing it up.
Yeah, no problem.
How about other discussion? You want to ask your peers?
This is Brenda, and I do have a question. If anybody provides blended formula, the organic, to their patients, especially for kids. Okay, that answers that.
Well, I apologize for not being able to answer that, but I am not in the clinical arena. I know about billing. But we certainly may. I don't know the answer.
Well, here's a little dilemma that we've come across. Patients that are actually children that the parents are requesting these organic formulas, and obviously the cost is quite a bit higher, and yet our reimbursement doesn't even cover the cost of them. And they're coming to us and stating, we've been told, well, we'll go elsewhere. And then also we've been told, well, the state of North Dakota told me to come to you now. Meaning what I took that as is people are pulling out of it and not being able to provide this because it is below the reimbursement is below our cost on it. And I just was wondering what other companies are doing. Are they just saying, no, they're not going to provide it? Or are they providing it to see if there's there are other items in that patient's claim? Does it outweigh the benefits? Can you get some reimbursement other places? We're just kind of not really sure where to go with this.
We have had that issue with our company as well, getting orders for organic. I don't remember exactly where we're at, but we had reimbursement issues for sure.
Mm-hmm.
I believe we're trying to steer away from it as much as we possibly can, depending on the referral.
Right.
From what I remember.
Mm-hmm. What I'm hearing from our home infusion department is that there's a group of parents, which I understand, they're going on websites and getting, this is what I want, and I want you to bring this in, and then it's well, if you don't bring it in, I'll go somewhere else, and it's something new to us, and we just want to be able to handle it appropriately, and kind of interesting to hear what other providers are they actually providing that higher cost or formula for them, or are they providing what they have on stock?
Taking any of your customers if they tell you that they're going somewhere else, because we don't provide organic to anybody. We never turn anybody away. We give them the options of this is what we have.
Mm-hmm.
And I don't mean to make this sound brash, but if they don't like it, they can go somewhere else, because I am not in the business to continue to lose money. We have a hard enough time making money with what we get reimbursed. So again, I don't turn them away. I give them, here's what we can provide, and I'm sorry I can't provide some of those things that people might want.
Okay. No, and I appreciate the feedback. It's just interesting.
I just reached out to our team lead who does formula. I mean, they do intake on the formula, and reimbursement is a struggle when it comes to the organic. Oftentimes that we don't get the reimbursement that we need, and so the branch manager will make the decision not to provide that particular formula. So reimbursement is an issue.
Yeah, case by case kind of. Okay.
Yep, depending on the brand, type, how much, all of that is kind of the information I'm getting.
Sure. Okay. Thank you. I appreciate that.
Mm-hmm.
Great question. How about, I'm going to throw another one out there that kind of shocked me of all the different thought processes is, how are you guys, how are you handling the cleaning of COVID equipment versus non-COVID? There was a lengthy discussion that there's been two extremes. One side is doing the 2 weeks quarantine, putting them out in sheds or putting them in somewhere. Others are like, you know what, we're confident in always been confident in our cleaning of our equipment, so we treat all equipment the same. We can't have a piece of equipment sitting somewhere for 2 weeks quarantining, or the hospital or the entity would leave the equipment in their quarantine area and have the provider come pick it up later. So any discussion you guys want to share, how you guys are handling COVID equipment?
Yes, I can start this conversation. In the beginning, we basically we went to the CDC looking through all of their literature and what their recommendations were as far as how long the virus can last and what kind of surfaces, what kind of temperatures and such. And what we ended up doing was we started to just do respiratory equipment that had filters, such as nebulizers and CPAP machines, that we would quarantine that. We started actually with 9 days because in the very beginning in March, that was some of their recommendations from the CDC. And again, we only did respiratory, where we would take it from the homes, we wipe it all down before we put it in our vans, transport it to in our store. We have a whole garage that was somewhat not being used, and we quarantined it for that much time. From that point, we then changed it up a little bit to where we now quarantine after a short period of time, just doing respiratory because of feedback from the staff and feedback from what we were seeing and hearing. We decided to do it with all pieces of equipment. So everything that we pick up from a patient's home, whether it's COVID or not, is quarantined right now because of the changes, because of the knowledge on what's happened with the virus. CDC, as far as what they're looking at and working with our epidemiology at St. Alexis as well, CHI St. Alexis, they are now talking about a 5-day window. So we quarantine everything for 5 full days before we go ahead and handle it. It's bagged, the date that was put into our quarantine area and covered, and that's where it sits until those full 5 days have elapsed before we actually take it into our, what we call our soiled room, before we go ahead and clean it. So that's the process that we use presently.
This is Pat. We were kind of doing the same as Kevin, only we only did the 72 hours. We'd bag it, bring it into our garage area, bag it, date and time it. But I guess I wasn't aware of the 5 full days quarantine. Is that what the CDC is recommending?
You know, it was interesting. I just had this conversation I did here with Brenda last week, and yeah, there was actually the last publications that I seen, because it depends on if you have metal or if you talk about plastic, if you talk paper, you talk foam. There's all kinds of different time frames in that, and the longest time frame was 5 days, and that's what I chose to go with then, is just do the full 5 days. It might be, and in some cases it's a couple days of overkill, but as I took a look at the full effect of what I'm doing and why I'm doing it, I just went with the furthest date out, again, being those 5 days. And that way I can be keeping the staff as safe as I possibly can and following the CDC guidelines to maybe to the, like again, to the nth degree, but it seems to work okay. You know, we continue to, I know there was some real concern about keeping that equipment, that I'm not using it, and it's a good point. That equipment's sitting there when it could actually be in another patient's home. But it took a little bit, you know, you got your 5 days, but every day you're pulling equipment from that hold that you have. So it's not real painful, even though you know there's equipment sitting out there. But if you stay after it every day pulling that, you're kind of keeping up with supply and demand, just having a few extra days sitting in the back room though. Is anybody else doing anything with their equipment as far as longer periods of time, or if you guys are holding it?
The holder is probably a couple days at most. It actually, our infection control states that it doesn't need to be, but we do, especially the COVID ones, but not the 5 days, we don't.
For Avera medical equipment, if it's aerosolizing, we do quarantine it for 3 days. But if it's not, we just go through our normal cleaning and disinfecting process.
That's good stuff. And I think, again, it's you're trying to find the guidelines and trying to be the most safe that you can be for your patients and for, you know, taking any risks that you guys may have. So it's just kind of interesting to hear different viewpoints from people. So does anybody else have anything they want to share regarding handling of the equipment? Remember, this is your meeting to ask questions of each other.
I don't have a question about that, but I do have a question that's kind of come up here recently, and I'd just kind of like to know how everybody else handles it. So you've got a patient that's on oxygen and they are they have COVID, and typically that's pretty short-term oxygen, but occasionally we have patients who are on it a little bit longer. And also sometimes we're getting orders for portable with that. So just kind of wondering what your follow-up is on oxygen with COVID patients, and there's a process that you use when you do get an order for portability.
That's an interesting question, because they shouldn't be moving around if they have COVID. Okay.
Yeah, exactly.
Last week we discussed just that matter, Cindy, where we were looking at what we should do for all these COVIDs just because of supply and demand. In the beginning, we used to do portables. You know, we'd give them a Inogen and a standalone. We've changed that now to where if they do have COVID, kind of like what Rose was saying, here's your portable, or here's your stationary concentrator, because you really shouldn't be out shopping at Walmart right now. And then we're giving them a couple e-tanks to get home and back and make their doctor's appointments and whatnot. So we've definitely pared down the amount of portable systems that we're giving just because of the cost. And you're right, they only get that piece of equipment probably for a month. So my expenses, I have a lot of expense to put out the piece of equipment and low reimbursement. So we're definitely have pared back on the amount of what kind of portable systems that they're going to get, and going with the more less expensive E's or D's or whatever it might be, so that we can lessen that cost. The respiratory therapist, though, did want us not to make a definitive ruling or guidelines for them, because based sometimes on the condition of that patient, based on the amount of portability that they need based off of where they live, obviously because we're all in the rural area here in North Dakota and South Dakota, they may need a portable system based off of other issues that they might have for traveling and whatnot, or their lifestyle to some degree. So we still left it up to the respiratory therapist to sometimes make a decision to do a portable system along with a stationary, but leaning much more heavy on just doing one stationary piece of equipment with a couple e-tanks to get them by to come to and from their hospital and office visits.
Okay. Do you follow up with those patients then to see when they're done with the oxygen equipment, or do you just rely on them to return it?
Well, for the most part, it's we are relying on them to return it, to know when they're discontinuing it, because you know, we've got some of those patients, as you know, they're needing that oxygen for a few weeks, and the next person's needing it for a couple months. Yeah. They're doing a lot faster discharges from our hospital now. We're getting at least a couple oxygen discharges a day that are COVID positives, not counting the other oxygen needs out there. So just discharges for COVID positive to get them out of the hospital. they're kind of all over the board as far as how long they're going to be keeping that oxygen and what their flow rates are. But because we're kind of at a surge capacity right now, Great Plains is seeing a lot more patients that are from hospital beds to particularly oxygen, where the increase is so much. And to keep up on all of that, Cindy, it'd be a lot to try to.
Yeah, no, I get it. I totally get it, because we're not either, but I just was wondering if other people were doing that.
And this is Pat from MedQuest. We actually are calling on those patients after the 2 months.
Okay. And what if they say they still need it? What do you do then?
We've been letting them keep them up to 3, and then we advise them to go see their physician or do a telehealth visit.
Okay. All right. Thank you. Anybody else do anything different than that?
I do have a question. This is Pat again from MedQuest. What are people doing with physicians who are wanting to send these patients home from the emergency room? We have 4 hospital facilities that we service right now, and we're being bombarded by the ER wanting to send patients home because they have no room in their med-surg floors.
Well, Pat, we have to establish that they still have to have the conditions necessary for the use of oxygen. Their SAT levels still have to be low. If somebody just wants to send them home with oxygen just because of the fact that they don't have the SAT levels or that are necessary for qualifying, then we're not supplying the oxygen because it wouldn't qualify. Now, granted, coming out of an ER, they're not in a chronic stable state, right? So typically, if you were doing billing Medicare or other insurances, it would be a non-covered service because they're not in a chronic stable state. Well, of course, coming from the ER, they're not, but due to regulation changes that we can do right now, it is a covered service, provided again, though, that they do qualify for that oxygen.
And just
Correct.
to piggyback on that a little bit too, like Kevin said, the testing is not required, but the medical documentation is a must. They have to have some type of medical documentation to support the need for it.
Right. We're making sure that they still follow the same guidelines as they did prior to the pandemic, except for the chronic stable state. But my issue is if they don't have the room in the hospital, are you still providing that oxygen, or should those patients be admitted? See, we're only doing COVID diagnosis patients out of the ER, granted that they qualify.
Avera is doing all needs for oxygen. If they need to be discharged to save a bed and they need oxygen, we are using the 1135 waiver in order to get those patients out of the ER and home, because we just don't have the capacity, and we are not making them be at the regular testing rate. They're also, and for sure for COVID, we're doing that as well. COVID's, as you probably all know, we learned that it's a higher oxygen percentage that they want to keep them at. They don't want them to be at 88. They want them to be at 93 or above because of what this virus is doing to some of the organs. Have you all heard the same thing?
I have not.
Okay.
I have not either.
I have heard some have been discharged with 10 liters.
They are going home on, a lot of them go home on the regular, and they ask for higher once they get them home. That's what we're seeing.
So yeah, we are letting them discharge with the 1135 waiver, even if their levels are not this qualifying.
Another potential with Medicare patients anyway is a CR modifier that can also be used due to the public health emergency that's going on right now. Just so you guys are aware.
I believe we are using that modifier.
Yes, we are too.
Yeah, we use that anytime we don't have qualifying
Qualified
criteria.
or no signature on your delivery ticket.
Yes.
Perfect.
That's when we use it.
All right, well, we are nearing we're at the hour. Does anybody have any final questions they want to ask of your peers? Did you guys find this type of session helpful? Is this something you guys would like to see in the future?
Yeah, I liked it.
Yes.
Yep, I agree.
Rose, thank you. This was good. It's a good conversation. Appreciate the work you did getting it together.
You're so welcome. Go ahead.
Would we want to set something up again in a couple months, perhaps?
Yes, I think that'd be good.
Okay.
Wonderful.
I think it would also be beneficial if we could get everyone's name and number if we had questions to call other providers.
Absolutely. Agreed.
Okay.
Agreed. Yeah, I will work with the board, Cindy and Kevin, and Brenda, and again, any other South Dakota folks that are interested in a possible board position in South Dakota, let Cindy or I know. Other than that, if you do have any follow-up questions or do have any comments that you want to make sure you share, make sure to send it to the MAMES office, Kevin or Brenda or Cindy. We'll be happy to respond, but thank you everybody for your time. We hope this is helpful.
Thanks, Rose.
Bye, everybody.
Thank you. Have a good day. Stay safe.
Bye.
You too. Bye-bye now.
Bye.